Ladies and gentlemen, esteemed guests and fellow healthcare professionals, a warm welcome to day 2 of the second OncoConnect Global Summit. I am Dr. Harshita, your host, and I am truly excited about the enlightening sessions we have in store for you. Before we immerse ourselves in the engaging discussions and presentations that lie ahead, let me take a moment to share with you the core mission and the goals of the summit. Our mission here today is simple yet profound: to foster collaboration, share knowledge, and ultimately advance the field of oncology. We believe that through collective effort and exchange of ideas, we can make significant strides in cancer care and research. Now, some of you may already be familiar with MedSynapse, but for those who aren't, let me provide a brief overview. MedSynapse is a dynamic platform designed specifically for medical professionals, a place where knowledge meets connectivity. MedSynapse connects over 1.5 million doctors from over 22 plus countries globally, with a focus on enhancing patient care outcomes. At MedSynapse, we also provide healthcare professionals with seamless, simple, fast, and secure solutions that facilitate clinical collaborations. But enough about the platform. Today, we have a remarkable lineup of interviews and discussions featuring some of the brightest minds in oncology. We had an absolutely remarkable day 1 with over 1,500 viewers and 33 discussions. It was truly eventful, and we eagerly look forward to today's session. For our first session today, we have with us Dr. Arsheed Hakeem, who will enlighten us on the management of oral cancer. Dr. Arsheed is a senior consultant specializing in head and neck oncology, currently affiliated with Apollo Cancer Institute, Hyderabad. Thank you so much for joining us today, Dr. Arsheed, and for taking time out to share your thoughts and inputs with MedSynapse medical community. We are eager to gain insights from your expertise. A quick note to our audience, do send in your questions in the comment section. We'll try and address all of them at the end of the session. Now, over to you, Dr. Arsheed.
Thanks, Dr. Harshita, for hanging me here and giving me an opportunity to present a lecture on oral cancer management. Now, if you see this slide, this is data from the GlobeCan, that's International Agency for Research on Cancer, which is showing the incidence of oral cancers in case of males and females all over the world. And if you see Indian subcontinent here, it's in dark blue. So means that the incidence is around more than 6.5 per 1 lakh population. And in females also, it's not less, it's around 2.5 per lakh female population, all ages. So means our subcontinent and particularly our country is a very high incidence area for oral cancers. The reason being rampant tobacco chewing, rampant alcohol use, and those people who also chew betel nut. And if the people who chew betel nut and tobacco along with the alcohol, they have much faster ingestion or of these carcinogens, and they result in more cancers, all cancers in our subcontinent. Now, if you go same data from GlobeCan, if you see the lip and oral cavity has been ranked second in Indian population. And around we see is 2020 data, we see around 1,35,929 cases in the 2020. It's not only the number of cases, but see the amount of destruction it is causing. See the number of deaths. Around more than half of the population is dying because of this. And India is going through an epidemic of oral cancers. Ranked second, almost more than half of the population is of those who are having oral cancers succumb to this cancer. It's a very immense. The government has to think about it. Now, what's oral cancer? Oral cancer is a cancer that arise from the oral cavity. 90%, more than 90% of these cancers are squamous cell carcinomas. And we have divided oral cavity into around 6 subsites: the upper lip, lower lip, right buccal mucosa, left buccal mucosa, alveolus, tongue and flora of mouth. These tongue and flora of mouth are very lymphatic rich areas. Then there's the buccal mucosa and palate. These and very important regions that's called retromolar tribe. They are these in these areas we have divided them according to the subsites because each subsite has a peculiar characteristics. Now, today my this lecture is based on basically the questions I get once we do some presentations or I teach the students or we are in conferences. Various clinicians ask us these questions, and I am trying to reply them or address those queries which are raised by the different clinicians. We have a way understood progression of oral cancers. Most of them they arise from a pre-malignant condition, go to the invasive cancer. So what's the most common pre-malignant condition we see in our population is a white patch or what we call leukoplakia. And this leukoplakia in around, there are various studies which say that from 0.4% to 20% transformation rate, depending on the size, depending on the site or the region it's in, it will transform into an invasive cancer. And most of these, we have three things what we make our decisions on whether to treat a pre-condition like leukoplakia or not. First is the clinical features. Second is the pathological, which is various grades of dysplasia. And third is the molecular. Now, if you see these all pictures, you can see these are various leukoplakias along with erythroplakia. This is in the buccal mucosa. All these three are in the tongue. Now, how to make decision whether we should treat it or not? Because we just want to know which leukoplakias are more likely going to be malignant or which are more likely going to transform in malignancy in oral squamous cell cancers. Now, the criteria, most of the, I'm sure the surgeons who are watching this program know that most of the decision making is based on clinical examination, not on the pathology, not on the molecular findings. So size determines whether we have to operate it or not. If it is in the tongue, if it is in the floor of mouth, you have to operate. And the clinical type, very important, clinical type, whether it is homogeneous, smooth like this picture, or whether it is non-homogeneous. Non-homogeneity means both in the color and texture. Whether it is rough, there's elevated areas, means it's a non-homogeneous. If it is in the females, you have to definitely treat it. If it is idiopathic, if there is no cause for leukoplakia like betel nut chewing or tobacco chewing, you have to treat it. If ulceration is developing, you have to treat it. And if there's an erythroplasia, like in these regions, red patches also, there's 20% more chance of developing cancers in such lesions. So they are to be treated. Now, as I told you, the main decision making is on the clinical features. Although pathology, various types of dysplasia, whether it's present or not, or what is the grade of dysplasia, they help. But majority of the clinicians make their decision based on their clinical examination. And combining, it has been seen that if you combine the DNA molecular findings of DNA ploidy with the grade of dysplasia, then the predictive value of such findings, means predictive whether that will develop into a cancer or not, increases. And basically a tongue, a floor of mouth has to be treated, has to be removed, and if it is non-homogeneous, it has to be removed. But I will observe still if it's a large, but it should be uniform, it should be very smooth, no elevations, no color change, no erythroplasia. It should not be on the tongue, it should not be on the floor of mouth. I still observe such leukoplakias. Now, how to treat it? Treatment is surgery, surgery, and surgery. And you have to triage. Triage means you find which are innocuous leukoplakias, which are likely, and from the leukoplakias which are high risk. What are high risks? As I have told you, size, non-homogeneity, erythroplasia development, or axillary dysplasia. These are high risks. What should we do in them? Stop the habits. They should immediately stop tobacco chewing or betel nut chewing or alcohol intake and resection with minimal margins. And those with are low risk, which means which are in the buccal mucosa, they are smooth, they are homogeneous, we can observe them. But provided they stop their habits of tobacco chewing or alcohol or betel nut chewing. Now, there are, once we talk of pre-malignancy, there are a lot of questions clinicians ask, and even patients in your day-to-day clinics, doctor, is there something that we can prevent and pre-malignancy going into malignancy? And this paper, which is a Cochrane review, is a review paper. This has addressed this issue of whether we can stop these pre-malignant conditions from getting transformed into malignant conditions. What they did, they had 14 studies, most of them were RCTs, and they had approximately 909 participants. And the intervention was they used different things. All these studies used separate studies used different things. Some used vitamin A, some used beta carotene, some used herbal extracts like tea and Chinese herbal extracts. Some used drugs like NSAIDs, ketorolac, celecoxib. Some used topical bleomycin, and some women bring big inhibitors. Now, what happened? They studied it with, along the placebo things. Now, what were the conclusion? What was this? This was a meta-analysis or intervention review. What are the conclusions of this study? The conclusions of this meta-analysis was that none of the medical or complementary treatment, none of them, neither vitamin E nor beta carotene nor topical bleomycin nor tea extracts, none of this was effective in preventing cancer onset in a pre-malignant condition like leukopenia. Although vitamin B and beta carotene, they may have effective effect on healing of these lesions, but the effect is very short term. The moment you stop taking these drugs, they will come up again, and there are a lot of side effects that are associated with these interventions. And my main argument against the use of these things is that if you stop the habit like tobacco chewing and you give them a good oral hygiene, they almost approximately 1/3 of these may regress. And we know that transformation occurs in only 1/3, and other 1/3 may become stable. So why to intervene in a case once we don't have a clear evidence that all these interventions are going to not help this cancer malignant condition go into a malignancy. So all the clinicians out there, I see in my clinic a lot of fancy drugs being used for these treatments. So till we have any evidence, we should not use. We should only treat them with surgery, which can be either a knife surgery or a laser surgery, which only those which are high risk. Now, second question, most of my students and my patients, these clinicians ask, what is the modality of choice of evaluating these cancers? You see, these buccal mucosa cancers, we need to know the state of primary tumor and whether the alveolus, the cortical bone is involved or not, because our management will change with that. And the best modality for such a case will be a contrast enhanced CT, which will give you a good idea of the primary tumors and give a good idea whether your cortical bone is involved or not. So the modality of choice for evaluating any buccal mucosa cancer is a contrast enhanced CT scan with a puff technique. So we can easily delineate the primary tumor and see whether their cortical bone is involved or not. Now, in case of tongue cancers, my discussion today is on anterior oral cancers. I'm not going to the base of tongue. I'm just concentrating on the anterior tongue. Like at tongue cancer. At tongue cancer, in which we need to know whether there is not a submucosal spread and what is the delineation of this tumor. So the best thing, all these information, the best way we can get is a MRI scan, contrast enhanced MRI scan, and that too contrast enhanced T1. You should ask for both axial cuts and sagittal cuts, and because MRI has a very excellent soft tissue delineation, it will give you very important. It will tell you whether how much is the extent both from medial to lateral and anterior to posterior, whether root of tongue is involved or not, whether it's extending into the soft tissues of the neck also. So if I have a tongue cancer, I will always do a MRI. And also one important thing, sometimes we may miss submucosal spread in tongue cancers. And in those cases, but most of the time, it will happen in very minuscule cases. Most of the times, if you are able to see, palpate the borders of the tongue, then there's no mucosal spread. and sometimes you may have a surprise, which happens very rarely. Now, if you have now we have all these investigating tools with us. We have an ultrasonography, we have orthopentomogram, we have a CT scan, we have an MRI, and we have a PET scan. So if we say that, let's take first ultrasonography. Ultrasonography has a very limited use in as far as if you are trying to see which is the assess the primary tumor. Some people have used in assessing the depth, but there's no clear-cut evidence that is efficient. And on the only use I see is a fine needle aspiration guidance for a neck node. If there's a neck node and you want to assess whether it's due to cancer or something else, that is the only use I see of an ultrasound in the neck. Some people use it for screening, but it's inferior to the CT or to the MRI or to the PET scan. Orthopentomogram, no, I don't use orthopentomogram in assessing cancer, oral cancers, because it will not give me details about the soft tissue component. CT scan, yes, is the modality of choice for assessing primary tumors and very efficient in picking up the cortical bone erosion. So I will always use them in the buccal mucosa. And MRI scan, yes, as I told you, it's better than CT to evaluate the tongue cancers and to see the thickness of the tongue cancers, even for small tumors, and to assess whether there is submucosal spread, and if there is a spread to the root of the tongue. But it's very poor in determining cortical erosions. Marrow infiltration, yes, it determines. And therefore, I will always use, once I have a tongue cancer, I will always send them for an MRI. Now, PET scan. PET scan is very superior to MRI as well as CT scan for assessing both cervical metastases and distal metastases, especially with once there's a advanced tumor stage, especially T3, T4, very advanced. So where will I do the PET scan? If I have large nodes, I have large nodes in the neck, or I have level 3, level 4 lower nodes in the neck, then I will definitely use a PET scan to see whether it has not any distal metastasis, because the chance of metastasis are more. And even if I want to assess the synchronous tumors, because there may be field cancerization in these cases because they have abused their mucosa, upper aerodigestion mucosa for a lot of time, and there's a chance of synchronous primary. So we should use PET scan in assessing the synchronous tumor. And I especially do these PET scans sorry, for patients who have been treated with chemoradiation. I do it particularly after 3 months to assess whether the treatment was the result of whether our treatment has been successful or there is a residual disease state. Now, how we came to know which modality we have to do was from this paper, which studied chest radiography and chest CT scan and CT scan of the head and neck versus the PET scan. So what did they see? They saw that if you see distal metastasis and a person, they had 3 arms. One arm, they chest X-ray was done and head and neck CT was done. Second, chest CT was done and head and neck CT was done along with the chest CT scan. And third, only PET scan, 18 FDG PET scan was done. If you see chest X-ray and head and neck CT scan, it picked up distant metastasis in 1.3% cases. If you do chest CT along with the head and neck CT, it picked up distant metastasis in around 2.6% cases. And if you see FDG PET, it picked up distant metastasis in 2.8% cases. Now, if you compare PET scan with the only X-ray, PET scan was far more superior in picking up distant metastasis, and it was statistically significant. Similarly, if you compare chest CT scan and PET CT scan, the result was not that. 2.6%, here it put 2.8. So it was not efficient in picking up distant metastasis. So doing a chest CT, although little bit of more, but doing a chest CT scan or doing a PET CT scan, distant metastases are not going to make any difference. Each is equivalent. Now, if you see synchronous cancers, chest X-ray and head and neck picked only 2% synchronous primaries. While as if you see chest X-ray and head and neck CT, it picked up 2.9%. And if you see FTG and compare it with the chest X-ray and chest CT, it was far more efficient with a very high significance. So PET CT is very important in picking up synchronous primaries rather than in picking up distal metastases if you compare it with the chest. So what this paper said, that a PET scan is far more better in picking up synchronous primaries, but distal metastases is similar if you do a good HRCT. Now, after you have done imaging, I told you which imaging you have to do. Now, after you have done, you stage the tumor. What do you stage? What does staging tell us? It tells us one thing, that we can give them prognosis, because if we have 4 stages, and depending on the stage, their 5-year survival depends. And second thing, we can compare, we can standardize the treatment by staging these cancers, because what is done in the USA should be done here, or what is done in one city should be done in all other hospitals or in all other cities. We have 4 stages of oral cancers. First stage is once the tumor is less than 2 centimeters or depth of the incision is less than 5 mm. Stage 2, if the tumor is less than 2 centimeters, but the depth increases, depth which I told you, depth of incision increases to more than 5, but less than 10. Or we can have more than 2 centimeter tumors, but depth less than 10 mm. Stage 3 will be once the diameter increases up to more than 4 centimeters, or any tumor which has depth of infiltration. We'll discuss a little bit more about the depth of infiltration after these slides, is more than 10 mm. And or if there is a perineural invasion of large caliber nerve which is more than 0.1 mm. Stage 4 has 2, 4A and 4B. If you take 4A lip, it is once there is a through and through cortical bone invasion, or there is inferior alveolar nerve involvement, or it's going to the floor of mouth medially, or it's infiltrating the skin, face skin externally. And stage 4A oral, if you take tongue, buccal mucosa, and all these alveolus, if it is through and through cortical bone involved, which can be either a mandible, maxilla, or antrum of the maxilla, or if it involves the skin, outside skin involvement. If you see a superficial invasion of the bone or socket of gingiva, if it's a primary tumor that's arising from the alveolus, gingiva, even if there is a superficial invasion of the bone and socket, it will go into stage 4. Now, stage 4B, we say inoperable cancers. Which are usually that invades either a masticator mus space, pterygoid plates, or skull base, or internal carotid artery. Now, T1, T2 buccal mucosa cancers, we resect them widely with adequate margins. What are adequate margins? I will come a little later. Like these 3 cases we have done, verrucous growth, we have removed them with adequate margins. This is the primary treatment of the primary tumor. In T1, T2 cancers of the tongue, we do intraoral wide glossectomy, as has been done in these 3 cases. Now, should we address, and if it is a clinically and radiologically N0 neck, should we address it or not? Now, we were all doing selective neck dissections, upfront selective, what we call elective neck dissections, or rather than doing the therapeutic neck dissection. If our imaging, if our clinical examination is showing that the neck nodes are not involved, we used to. But the proper evidence was shown by this paper, which was from the Tata Memorial. We showed that the overall survival in an oral cancer, if we do an upfront elective neck dissection despite N0 neck, enhances the survival. So from that paper, that gave us a first evidence, a documented evidence. Otherwise, we were all doing all these neck dissections in these early tumors also, like in this early tumor of the neck. And what strengthened this? These 2 papers, which was elective neck dissection, improves the survival of patients in T2, N0, M0 oral squamous cell carcinoma, a SEER database study. This strengthened it, and understand what we in our language call SENSE study showed that if we do elective neck dissections for even early oral cancers, the overall survival is enhanced. So all cancers, all doctors are presently doing upfront neck dissection for even N0 necks. Now, the only thing which I see, if it's a tongue, it's a floor of mouth or alveolus, I always do neck dissection. But if it's a unlike this cancer, a small cancer which is mobile, and my radiology has not shown any neck involvement, and the patient is ready to follow up me for under 2 years vigilantly, and there are no other features which say that he needs an adjuvant treatment, I will definitely operate this with the only wide local excision and keep him under observation for the neck. Otherwise, all these studies, they all favor upfront leg to neck dissection in N0 necks. Now, as far as the treatment of oral cancers is concerned, what other, apart from like early oral cancers, we operate and the advanced cancers, we operate and give radiation, where we should give radiation. If it is a T1, T2 cancer, margins are more than 5 mm. There is no lymphovascular invasion. There is no perineural invasion. You have dissected the neck. It has pathologically come as N0, no nodal involvement. Surgery enough is allowed. And you have a good survival. If it's a T1, more than 90%. If it's a 2, they can have more than 80% survival rate as far as 5 years are concerned. Now, if it is a stage 3, stage 4 disease, he will definitely need adjuvant treatment. If there are close margins, so my request to all surgeons is try to ensure the margins are more than 5 mm. There may be some technical difficulties not taking complete 5 mm margins or more than 5 mm margins, like you are operating in a lower alveolar, lower gingival buccal servus, and you don't want to touch the teeth or alveolus. So in those conditions, it's okay, but you should try to always have pathologically more than 5 mm margins. Otherwise, most of your cancers, which are even early T1, T2 cancers, may land up in radiation therapy, and which is not good. And if it is now a T3, T4 cancer, close margins, lymphovascular invasion, perineural invasion, positive nodes without extracapsular extension, they will go for post-operative adjuvant radiotherapy. If margins are positive or there is an extracapsular extension, then he will need or she will need postoperative radiation along with the chemotherapy. Now, there are some controversial issues here which I would like to address. Number one is the close margin. There's a lot of controversy around it. What is the close margin? Tumor, once a tumor is reaching within the 5 mm of the inked margin on the specimen, we take it as a close margin. And some like this paper has seen that there's around 40 to 50% syncate post fixation. So a margin which was 1 centimeter shrinks post fixation by 50%. So should we take this as if we are getting only 2 mm margin on the post fixation, should we take it as a positive or close or what? But these studies, if you have see these two studies address this issue, and they said if it's a 2 mm, more than 2 mm, and it should 2 mm should be cut off. If it is more than 2 mm, it should be a negative margin. If it is less than 2 mm, it should be a taken as a closed margin, and that is post fixation. Now this addresses this closed margin issue. Now, another controversy is, as I was talking to you earlier, depth of infiltration and tumor thickness. Is it same? No, it's not same. Thickness, and why we are in that impressing or significantly saying got 11 more than 10 mm, because there's a lot of studies that have shown that thickness of more than 10 mm is significantly affecting the overall survival in oral cancer patients. Now, what is difference between a tumor depth of invasion and tumor thickness? Depth of invasion, you see, if you take a straight line from the horizon of the basement membrane and then put a particular perpendicular line to the deepest point of invasion. From the uninvolved mucosa, you have to see and take a deeper perpendicular line to the deepest point of invasion, that your pathologist will tell you that is the depth of invasion. And the depth of invasion has been significantly seen to be related to the survival in oral cancers. That's why it's included in the 8th edition of the tumor classification, which I have just pointed to you. And tumor thickness is, if you take, that's the invasion of the tumor from the surface of the tumor up to the deepest point. If it is an endophytic tumor, the depth of total thickness will be more. And if it is an exophytic tumor, it will be more. If it is an endophytic tumor, the death will be less. But that it's not the depth, tumor thickness, it's the depth of invasion that has been seen to be significantly affect the overall survival. That's why it has been incorporated in the recent or 8th edition TNM staging from the American UICC. Now, another controversial issue is if you get you have operated the patient, you have only T1 disease or T2 disease, there are no bad features, there are no pathological features which point out to the radiation, but then one neck node comes out to be positive. What should you do in this condition? My suggestion is to discuss it with the pathologist. If the node is fully involved, means there is tumor everywhere in the node, then he will definitely need radiation therapy. But if there is only a micromet, small metastasis, 2 mm, 1 mm, 2 mm, 3 mm spot of metastasis of tumor, and the person and the surgeon has done a good quality neck dissection, which is a good quality neck dissection is around taking 15 to 18 nodes from the neck, then I will observe that case. So, sorry. If it is a full node involvement, you have to definitely treat him with adjuvant radiotherapy. If it is a micromet with only small 1 or 2 mm spot of cancer and a neck dissection, good neck dissection has been done, then you observe it. Another issue which I am frequently being asked is the role of frozen section in oral cancer. Do we have to have negative margins once we do surgery? And this issue was addressed by a meta-analysis that addresses this issue, that they took that local recurrence-free survival from 8 studies. And they assessed it. They said among them, there was a group which was initially R0. That is, the margin was more than 5 mm. Initially, once you operate, and then initially there was a subgroup where all the margins were negative and they were more than 5 mm. And there was a group where there was R1, and along once they did a resection, that's in the frozen intervention. That was the intervention in the frozen. And what we say R1, once it's a positive, less than 1 mm. And if it was 1 or 2, 1 to 5, more than 1 and less than 5, we take it as a close. So they revised the margins in them. And then they had two subgroups in that. One was initially R1, and then with the frozen section said there's a margin positive, and they resected it. It was more than 5 mm. They said this is a group from R1 to R0. And the other group, which despite the resection, had a positive margin. So what did they find? They find, if you compare R1 group with the R0 group, its local recurrence-free survival was statistically significant, particularly in the tongue and in the flora. Then if you see that, if you take that group where there was a R0 initially, R1 initially, and with the frozen section, it got to R0. And they compared it with the R1. They did not find statistical significance. So margin revision of an initially positive margin to a clear margin based on your frozen section does not equate to an initial negative margin. Although if you compare this group from R1 to R0 to R1 group, it showed there was a trend. Those who had from R1 to R0 in the frozen section, and those who had positive margins after intervention also, there was a trend towards better. They had a better survival. But it did not statistically signify, or it did not say that the results, overall survival, was similar to initially R0 group. So always surgeons, the first surgery is the best surgery. Try to initially resect it have the margins more than 5 mm. Now, another thing is, what margin should we take in oral cancers? It's always radial margins, and that margins are to be guided by your specimen. Let them discuss with pathologist. Let him gross it and at least do frozen section. Grossing will tell you exactly what, just after cutting the specimen, take it. You can even take it. Our frozen section lab is just opposite our theaters. So we just take the specimen, we discuss with the pathologist, and they will take the gross margins. And they will see on frozen section which margins are in. Most of us know that we do this frozen section more of compulsion. We don't want to get involved in any medical legal issues, and we want to once we operate, we talk to the patients and their relatives, and they want to know whether you have really done an R0 resection or not. There's a documentation, and it has always to be specimen driven margins, and that too radial margins. If you dissect the specimen and then send the margins, then you are going to be inaccurate in around 40% of cases. So that has very, very significant statistical that our survival, we may have a positive margin in spite that you have taken the margins from that area which were negative. That is not the real margin. So all the surgeons have the specimen-driven margins rather than resecting the specimen and taking it from other places after resection. And keep in mind that post-fixation, there may be synchrage of 15 to 46%. If you see Tata Memorial data, is around 22% more in the T1 and T2 lesions rather than T3, T4 lesions. And if you see Iowa group, that was based on the canine model, it has around 47% shrinkage. So aim at 1 centimeter. I will always take 1 centimeter margin so that I have at least 5 mm pathologically. And it will also take care of my associated dysplasia, surrounding dysplasias, if I take 1 centimeter margin. So always aim at 1 centimeter so that you have 5 mm clear margins. Now, T1, T2 we have discussed. T3, T4, what we call locally advanced cancers. They can be divided into two: operable, inoperable. If it is inoperable, we have to do surgery, followed by, which is most of the times, composite resections, meaning either a cheek composite section or major glossectomies in case of tongue, or cheek composite section in case of buccal mucosa. And we do surgery. After surgery, we treat them with radiation therapy or chemoradiation therapy, depending on the pathological features. Now, if they are inoperable, then we treat them with either symptomatic care, supportive care, take care of their nutrition, take care of their pain till whatever time God has given them, or we can treat them with chemoradiation, depending on the clinical scenario. Now, what are signs of inoperability in oral cancers? First, majority of cases we find large fixed nodes or skull-base involvement, internal carotid artery encasement. In case of buccal mucosa, there may be extensive soft tissue cheek involvement, and that may go up to the zygoma. Then we don't operate. And in case of tongue, it can be an extensive soft tissue involvement of the submandibular region, or it may go to the back in the base of tongue up to the involving the hyoid bone. So if hyoid bone is involved, some of these can be still operated, but then they may need total glossectomy along with some form of laryngectomy. The results of those, some people say operating in such cases is not good, as the results of the survival is not good in such cases. Now, another area of interest, another area of questions which are frequently being asked to me is whether we should remove if the oral cancer is extending up to, particularly buccal mucosa cancer is extending up to the infratemporal fossa. Now, this to some extent, this classical, if you see the classical teaching, these cancers are inoperable. They have very poor results. But now we operate some cases. Because of this study by Leo, he said that oral cancers, if they are below the mandibular notch, they have same outcome, they have a favorable outcome, same outcome as any T4A lesion, which is not involving the infratemporal fossa. But this was this study, but my suggestion will be that I select my cases where I will do infratemporal clearance very, very strictly. I will go to the radiologist, I will discuss with him, and I will see if there's a gross, it's a plaster disease around in the ITF, gross disease in the ITF, which is extending above this notch. And I discuss mainly with my radiology colleagues, then I don't operate them. But some cases, definitely, we do infratemporal fossa clearance. And they have good they I will say they will not have that overall survival as a tumor without involving the ITF. So, but and this is an area where I will always use frozen section. Frozen section is very important in these cases to know whether I have cleared the disease or not. Thank you. I think I have addressed it, not all, because this is a very vast. We need a lot of sessions if we want to discuss it in detail. But some of the issues which are very important, which most of the times, if I do a presentation or I go for a teaching session, most of the clinicians do ask all these questions, and I have tried to address these issues in a scientific way, in the view of in the background of the evidence we have up to now. Thank you.
Yeah, thank you, Dr. Arsheed. It was highly engaging session, and we do have questions coming in from our audience that we would like you to answer. So the first question is, in what scenarios are chemotherapy and targeted therapy recommended as part of oral cancer treatment?
Chemotherapy, we have three scenarios. There can be a neoadjuvant chemotherapy if we want to give it before, if there's really very advanced buccal mucosa or tongue cancer, and we feel that our margins are going to be compromised. So what we use in the neoadjuvant form, we first give them 3 cycles of chemotherapy and try it. If the tumor shrinks, then we operate them. Like we have a buccal mucosa cancer that's going above the zygoma, is not nobody will like to operate a cancer which is going higher. So although there's a TMA Tata Memorial data, but it's not a efficient data, so we have to make our decisions really based on our clinical experience. There's a Tata Memorial data that suggests that there is, if you give neoadjuvant chemotherapy in such cases, we can address them later on with surgery, which are much better margins. And second is adjuvant. We use it along with the chemotherapy, along with the radiation therapy, because most of the cancers in oral cancers, we treat them with surgery, early cancers, and advanced cancers, we treat them with surgery and followed by radiotherapy. If there are multiple, there is a margin is closed, or it's a positive margin, or there is a node where we have a gross extracapsular extension, then we treat them with chemotherapy and radiotherapy. And the third and final is a palliative. If we have a cancer that has gone beyond the resection, or we have treated that and it recurred like an ITF or some other places, or it's causing a lot of fungation of we can use palliation. We use in those scenarios, we use palliative chemotherapy. Now, as far as immunotherapy is concerned, we have targeted therapies, but they are very costly. And we use them in the metastatic. Most of them are used in the metastatic setup.
Yeah, and another question is, are combination chemotherapy regimens commonly used in oral cancer management? And what are the potential benefits of combining different drugs?
That's important thing. That's mostly those are we use in neoadjuvant chemotherapy. If we have a big tumor, I want to shrink that. Or if we are using a chemo radiation as a first treatment modality, then we use multi-drug regimen is already used, is mainly used in the neoadjuvant chemotherapy. We use different chemotherapy drugs so that they have effect on the different cycles, phases of the life cycle. So we can have a better effect. That is the main aim, and shrink the tumor. That's mainly in the neoadjuvant chemotherapy. If you are using it an adjuvant, we use single drug therapy along with the radiation therapy. In palliation, we may use a 1-drug regimen, or we may use a 2 or 3 drug regimens. We use them in the palliation also. They have a benefit there, a proven benefit.
Yeah. So thank you, Dr. Arsheed. Thank you for your answers and for sharing your valuable insights today. Your contribution has been truly enriching for our symposium. And to our audience, thank you for joining in.